Hello, everyone, and welcome to our Community Conversation on Cancer series, sponsored by Wilmot's Office of Community Outreach and Engagement and its Community Cancer Action Council, or CCAC. I'm Christina Hawes from Wilmot's Community Outreach and Engagement team and the facilitator of our CCAC. It's my pleasure to celebrate National Dress in Blue Day by facilitating today's special edition discussion titled, Let's Get Fit, Colorectal Cancer Screening at Home. Community Conversations on Cancer is an educational series designed to inform, educate, and disseminate best practices in cancer research, clinical care, and community engagement. Over the course of the series, topics will address the social determinants of health, improving cancer care delivery, and promoting health equity across our 27-county catchment area. This live event has been approved for 1 AMA PRA Category 1 credit, 1 CNE credit for nurses, and 1 contact hour for social workers. Today, we will have a presentation followed by a panel of experts willing and able to answer any questions that you have. Throughout the presentation, please feel free to enter any questions in the Q&A box at the bottom of your screen. Now I'm pleased to introduce you to our presenter, Dr. Christopher Walker. Dr. Walker is a third-year fellow in U of R's Department of Gastroenterology. He's a graduate of Eastern Virginia Medical School and completed his residency here at the University of Rochester. Chris has special interest in inflammatory bowel disease and health equity. I will now turn it over to Dr. Walker.
Thank you very much. Good evening, everyone. Hope everyone is enjoying their day. I'm just going to go ahead and share my screen. Okay. All right. Hello everyone again. My name is Chris Walker. I'm one of, as mentioned, I'm one of the third-year gastroenterology fellows at University of Rochester Medical Center. I'm very happy to be here and have this opportunity to talk with you about colorectal cancer screening. I'm truly grateful that you all took the time to be out to be a part of this session, especially to kick off this Colorectal Cancer Awareness Month. I'm hopeful that you'll find this session helpful and that you'll leave here with a few tips and recommendations that you can share with your friends and your family. So today we're going to talk about colorectal cancer screening and specifically FIT testing. We'll talk about what FIT testing is, how it works, who should do it, when you should do it, and so on and so forth. Hopefully we'll touch on everything you'll want to know about FIT testing between this talk and the Q&A session. But before we get into that, I just want to remind everyone what screening is. So screening is the process of testing an entire population for a particular disease in order to find out who has that disease. So when we talk about colorectal cancer screening, we're talking about doing a test like a colonoscopy or a FIT test, doing that test to find out who has colon cancer and who does not. So why is this important? Well, unfortunately, colon cancer is the third most common cause of cancer in the United States. And for the year 2023, the American Cancer Society is estimating that there will be over 153,000 new cases of colorectal cancer. It's the second most common cause of cancer-related deaths in the United States. For the year 2023, the American Cancer Society is again estimating that there will be over 52,000 deaths from colorectal cancer in the United States. And even though this information is out there and it's being spread during forums like these, there are still 23 million Americans who are eligible for colorectal cancer screening, but have not yet undergone screening. So again, why do we screen for colorectal cancer? Simply put, because screening saves lives. The colonoscopy first came out in 1969, and in the 1970s, it became a regular part of preventative health. And you can see in this, hopefully you can see my laser pointer here. In the 1970s is when it started becoming a regular part of preventive health. And there was this initial rise in colorectal cancer cases, but right around the 1980s is when we start to see a relatively steady decline in colorectal cancer cases. And it's been dropping at about a 1% per year. And this is largely attributable to the screening practices that have taken place over the past few decades. So who should be screened for colorectal cancer? The answer is simple. Everyone should be screened for colorectal cancer. The next question that we ask is, well, when should you start screening? So when you should start screening differs from person to person. It all depends on your risk for developing colorectal cancer, and you'll either be put in the average risk category or in the high risk category. High risk individuals are those who have a family history of colorectal cancer, or they have a family or personal history of genetic syndromes that are known to increase the risk of colorectal cancer. People who have a personal history of inflammatory bowel disease are also considered high risk. And everyone else, everyone who doesn't fall into those categories, they're considered average risk. So average risk individuals should start screening at age 45, and high risk individuals should start screening earlier than that. And the exact timing depends on the details of that person's personal history or their family history. But in general, it ends up being earlier than age 45 for that group. I just want to mention here that if we focus in on the average risk population, we can see that there are certain things that can increase your risk of developing colorectal cancer. So for example, rates of colorectal cancer are higher in people with type 2 diabetes, people who smoke cigarettes, or people who drink a lot of alcohol, and even in people who eat a lot of red meat or processed meats. So it's in general, in terms of things that we can modify to decrease our risk, we usually recommend that these things are avoided so that the risk is lower and lower. We also see different rates of colorectal cancer among different genders and different racial and ethnic groups. The risk of getting colorectal cancer is higher in men compared to women, and the risk in non-Hispanic Blacks getting colorectal cancer is higher than that of other races in America. These facts are worth keeping in mind while we think about screening, especially when we're thinking about ourselves as individuals, our family members, so on and so forth. Like I said, this is still thinking about the quote unquote average risk group. So these things don't necessarily change the timing of colorectal cancer screening, but it is something that we should keep in mind when we think about this. So we've talked about what colorectal cancer screening is, why should we screen, who should we screen, how do we actually go about doing this? Well, there are three main ways to do this. You can do a stool test, and the stool test, there are three different stool tests that could be done. One of them is the fecal immunochemical test, or the FIT, which we'll be talking mostly about today. But there are two others: the guaiac-based fecal occult blood test, the multi-targeted stool DNA test. Those are two other stool tests that are available. The other ways of screening are with a CT scan, referred to as CT colonography, and colonoscopy. Like I said, we'll focus in on FIT today. So a fecal immunochemical test is one of the screening tests used to evaluate for colorectal cancer. One of the early signs of colorectal cancer is bleeding within the GI tract from the tumor. So sometimes there's bleeding from the tumor that you can see to the point where you could see the blood in the stool. And other times there's bleeding from the tumor, but it's at a rate that's so low you can't see the blood in the stool. So that's where the FIT test comes in. It's able to detect very small amounts of blood that otherwise you wouldn't be able to pick up with your human eye. The results of the test are either positive or negative. Positive result means that the blood was detected in the stool, and therefore there's a possibility that it's due to colorectal cancer. And a negative test means that no blood was detected in the stool. And just to point out, there are other reasons why someone could have blood in the stool, things like inflammatory bowel disease, hemorrhoids even, so on and so forth. So the FIT test doesn't necessarily distinguish between the other reasons to have blood in the stool, but it does pick up on whether or not there is some amount of blood that's in the stool. One of the biggest advantages of this test is its convenience. After you provide the stool sample, you can get a result in minutes. It's non-invasive. It essentially carries no risk to the patient. And there's no need to do any bowel prep before the test, which you would need to do for a colonoscopy, or you'd also need to do that for a CT colonography. Even the short colonoscopy, known as the flexible sigmoidoscopy, you'd have to do some form of bowel prep before that. And not having all these different things certainly makes the test convenient. There's also no need to follow any particular dietary restrictions or avoid any specific medications because these things don't interfere with the test results. It's noteworthy because prior versions of this test were affected by things that we eat or medications, etc. So you'd have to pay close attention to that when trying to interpret the results. But that's no longer an issue with FIT testing. You can get a fairly accurate result for what it does with just one sample. Depending on some of the older models, there might be multiple samples that are obtained, but with what's available today, one sample tends to be enough. So this is a short video from UCLA Health. It shows us how to complete the FIT test. The FIT test is a stool test. It's not a blood test. So even though the instructions are pretty simple, the process may not be something you're familiar with. So I want to show this video just to help illustrate the process.
No one really likes to talk about it, but a little bathroom talk may save your life. Having a reliable way to detect colorectal cancer early can make a big difference. The fecal immunochemical test, FIT screening method, is the standard of care for early detection. To get your test, visit your physician and request a FIT test. Once you receive your patient pack, double-check you have all the contents that should be in your pack. If indicated, clearly write your information on the bottle or requisition. When you are ready to have a bowel movement, place the collection paper inside the toilet. Collect your stool on top of the paper. Twist the green cap on the sampling bottle to open the bottle. Collect your stool sample before the paper sinks by scraping the surface of the stool sample with the wand attached to the green cap. The grooved portion at the tip of the wand should be completely covered. Now, reinsert the wand into the sampling bottle and snap the green cap on tightly. Do not reopen. Okay, Just finish your business and flush the biodegradable collection paper. Double check that you have recorded the collection date on the bottle. Then, wrap the sampling bottle in the absorbent pad and insert into the biohazard bag. Place the biohazard bag with your sample inside the return mailer. Seal the return mailer securely and drop the prepaid mailer into the mail. Your sample is perishable. Mail your sample promptly, ideally the same day you collect it. You will be notified by your medical provider about your test results. If your result is positive, it's important that you contact your doctor to schedule follow-up testing. If your result is negative, mark your calendar for 1 year from today to take this annual test again. Get screened with FIT today.
So I hope everyone can see from that video, fairly straightforward, and it emphasizes again how convenient this test is. Something that you do at home. You can still be, in the privacy of your own bathroom, in a comfortable space, rather than being in a lab, etc. And it is a test that is very convenient. One sample, and then, like they said, if the test is negative, you'll have to do it again in a year, and the process is exactly the same. So we've talked about the convenience, we've talked about the benefits. I want to show this chart here. This is a chart from a study that was performed some years ago. And this study compared colonoscopy to FIT to see if one was any better than the other at identifying certain types of lesions in the colon. So I won't go through the statistics here, but I'll point out that the different lesions that they're looking at here are cancer, and then these here are different types of polyps. When they compared FIT testing to colonoscopy while trying to identify cancer, they've essentially found that there's no difference, meaning that the one is just as good as the other. FIT testing is just as good as colonoscopy, according to this study, when it comes to finding cancer. The big difference, though, that this chart is showing is that the FIT test is not as good at detecting other lesions. So just as a brief reminder, colon cancer first starts out as precancerous but benign polyp. And over time, that polyp grows and turns into cancer. So the FIT test does a good job of letting us know when cancer is present, but it's not as good as letting us know when a polyp is present before it turns into cancer. And that's what some of these numbers are showing us here. That cancer, colonoscopy, and FIT test are almost interchangeable, according to this data. But for polyps, precancerous lesions, the colonoscopy outperforms the FIT test, does better than the FIT test. This is another diagram that tells a similar story. I won't get into the specifics of the statistics here when it comes to sensitivity and specificity, but I do hope you can appreciate that these things are high, 98% and 96%. But again, this is specific when it comes to detecting blood in the stool, which is what the test does, and being able to correlate that blood in the stool with colon cancer. When they are looking at precancers, this study remarks on statistics in the 60% range. Other studies may report things as low as 24%, in the 20s. So there's some variability in some of the different studies, but the point is that it's significantly lower. The the ability of the FIT test to detect a precancerous lesion is significantly lower compared to its ability to detect cancerous lesions. And the reason behind that is because polyps, especially when they're early, they don't bleed. Certainly not as much as a cancer would. Cancer, especially as it grows and grows, it can become what we refer to as friable and start to bleed spontaneously. So that's how the FIT test is able to pick up on the cancer, but it's not able to pick up on the polyps before they turn into cancer. So as we mentioned before, the advantages of this test, mostly its convenience. We should know that there are some limits to the test. And the big limitation is that it has a reduced ability to recognize the presence of polyps or precancerous lesions. This is part of the reason why the FIT test actually needs to be repeated every year. The early detection of cancer is important. It allows for early treatment, which increases the likelihood of successful treatment. And cancer treatment options often include surgery, chemotherapy, and/or radiation. When we think about preventing cancer, however, the removal of precancerous lesions allows us to do that. It can put a halt to the progression of a polyp towards cancer, and thereby it essentially eliminates the need for surgery, chemotherapy, or radiation because the polyp has not progressed to cancer. So this speaks to the fact that FIT testing is what we refer to as a diagnostic tool, and it is not therapeutic. In other words, you can diagnose a problem with a FIT test, but you can't treat it. So just like what was mentioned earlier, if your FIT test is positive, you'll need to schedule a colonoscopy to confirm why that FIT test was positive and also treat whatever issue that was creating the positive FIT test. So it's important for us to keep the limitations in mind because they remind us that everyone can't have a FIT test. People who are at high risk for developing colorectal cancer should not have FIT tests done because this mode of screening is inadequate for that population. So people who have a family history of colon cancer, a personal history of inflammatory bowel disease, personal history of genetic cancer syndrome, so on and so forth, these individuals have to pursue colorectal cancer screening with a colonoscopy. So FIT testing is only appropriate for those who are at average risk for developing colorectal cancer. And that's something that we should all keep in mind. So after hearing all of this, you may ask yourself, well, what do I do next? The next step is to talk to your doctor. You should let your doctor know what your family history is and whether or not you have any GI symptoms. Let your doctor know about any bloody stools, abdominal pain, so on and so forth. And together, you and your doctor can decide which test is best for you. If you're in a high-risk group and you're at the age where screening should be starting, we'll talk to your doctor about colonoscopy. If you're in an average risk group and you're at the age where screening should be starting, then you'll talk to your doctor about some of the other forms of screening, whether that be an annual FIT test. There's also the option of the short colonoscopy and combining that with a FIT test, so on and so forth. And one thing that I like to make sure we all know is we often talk about colonoscopy as the preferred method of screening for the general public because it is a diagnostic test that can find cancer and precancerous lesions. And it's therapeutic. It can treat precancerous lesions before they turn into cancer. But even though we say that's the preferred test, the best test is the test that actually gets done. So if for whatever reason someone can't pursue a colonoscopy or doesn't want to pursue a colonoscopy, it's important to know that other options exist, just like the FIT test. And the FIT test is a great test. It is recommended for people who are not pursuing other modes of screening, and it can just like the other modes of screening, it can help save lives. So thank you for the time. I appreciate the opportunity to talk with you, and I look forward to our Q&A session with the rest of our panelists.
Thank you, Dr. Walker, for that very interesting presentation. I saw a lot of things today that I have never seen before. If I could have all of the panelists please turn their cameras on. We will start our panel question portion of today's event. Just as a reminder, if you have any questions, please enter them in the Q&A box located at the bottom of your screen. You can answer that or ask the question anonymously, so don't worry about being embarrassed about anything that you put in there. We won't know that it's you. Additionally, if you have a question for a person on our panel specifically, please just make sure that you write their name in when you write the question so that we can go through and give it to the correct person. So now let me introduce our panel. So in no particular order, we will start, oops, I apologize. We will be starting with Dr. Danielle Marino. Let me add her here. Dr. Marino is a gastroenterologist and is also the director of the Hereditary Cancer Screening and Risk Reduction Cancer Program. She is passionate about coming up with treatment plans with patients. Oh, I'm sorry. She is passionate about colorectal cancer screening, prevention, and genetic testing to help figure out people's risks of getting colorectal cancer. We also have Parnisha White, who is a board-certified nurse practitioner in colorectal surgery and is also the first advanced practice provider, diversity, equity, and inclusion officer at URMC. She is a Rochester native, advocating for patient engagement, education, screening, and prevention. We also have on our panel today, Sparkle Wells. Sparkle Wells is a community health project coordinator for the Cancer Services Program of the Finger Lakes and the Promote Health, Prevent Cancer initiative. She is also a board member for the Rochester Regional Coalition Against Human Trafficking with an interest in behavioral health and community outreach. And last but not least, we have Dr. Lisa Cannon, a colorectal surgeon that believes in coming up with treatment plans with patients so that they're active in all decisions. So with that, we will start with our questions. So we had a couple of questions that actually arrived through our registration that I want to get to first. These are open to anyone to answer, so please feel free, all of our panel. The first question, which I very much appreciated, and I think that you all will as well because everyone's thinking this. What exactly comes in a FIT kit? In parentheses, does it come with gloves? And where does it go once I mail it in? Let's see.
Okay, well, I happen to have a FIT kit here with me. It comes in this envelope. Inside, there is a secondary envelope to send off to a lab. The kit is sent to a U of R lab to process. There's a consent form in that you will send in, and this one is sealed. But it comes with 2 brushes that look similar to like painting brushes. It comes with a little card that has, what would I equate them to? Like a gauze pad on it that you can use to dab the brushes on. And it comes with 2 small trash bags. It does not come with gloves, but you have everything in here you need to do so safely.
That was a very good question. So what I'm hearing is if you feel like you need gloves, make sure you have them before you take out the FIT kit. Okay, so on to our next question. This comes from one of our CSP partners out towards the eastern part of our state. And the question is for providers. I'm curious if providers that are noticing patients that aren't scheduling colonoscopies and are overdue for screenings are recommending at-home screening tests and discussing the option of different types of tests for home tests. We're finding that Cologuard is mentioned most often, but it can be very difficult to pay for or to have covered. So I'm not sure whom would be, Dr. Marino, do you want to maybe try and take this one?
Sure. Yeah, I mean, I think, like Dr. Walker mentioned, colonoscopy is kind of the best option, but there are a lot of barriers to that. And so when discussing colon cancer screening with patients, we really should be discussing all the options. Cologuard is the multi-target FIT DNA stool test, and it is about 100 times more expensive than a FIT test. And so, yeah, not all insurances cover that. I think that all options should be discussed with the patients, pros and cons should be discussed with patients, and then deciding together about what the best option for that patient is. If patients can't have a colonoscopy for whatever reason, they can't get the day off, they don't have a ride, there's plenty of reasons why patients may not be able to do a colonoscopy at a given time, then stool testing is certainly a good option. But if they can't ever have a colonoscopy, then there's no sense in doing the stool test, because as Dr. Walker mentioned, it needs to be followed up with a colonoscopy. So, having that discussion and going through the options is very important for each patient. I hope I answered that question. I don't know if Dr. Cannon, you want to add anything, or Dr. Walker.
I like your notion about the easier access to the FIT as compared to Cologuard, but I think we are seeing this a lot because of the COVID-related backlog and ability to gain access to colonoscopy in a timely manner. And so for patients who are otherwise healthy with no risk factors, who are kind of in that backlog of colonoscopy patients, a FIT test could be a good choice for reassurance. And if it were positive, could help kind of shortcut to the colonoscopy, because there are some kind of priority columns for how we organize scheduling colonoscopy.
Yeah, that's a really great point, actually. That's so, when it takes so long to get patients in, if we could triage people and get the people with the positive tests in first, that would be a great way to get this done when we have such a big backlog. But patients need to be aware of that, because sometimes, unfortunately, insurances may cover it differently, a colonoscopy, if you're doing it for a positive FIT test than if you're just coming for a screening. They may bill it differently, so patients need to be aware of those issues as well. But that's a great way for us to kind of triage who needs to get in the quickest.
That is a great segue into one of the other questions that we had that came through our registration, which was, why is it that sometimes people go in to get a colonoscopy, but are then charged for it when it's supposed to be a free screening?
It's because of insurance companies. Unfortunately, there's been this kind of loophole where screenings are supposed to be fully covered, but sometimes if we find a polyp and remove it, the insurance companies will bill that as a diagnostic. Thankfully, that will be ending soon, because there was a bill in Congress that did finally pass to get rid of that loophole. But this whole positive FIT, if we do a colonoscopy for a positive stool test, that is billed as diagnostic. And so that would be another reason that there would be a copay involved. So patients do need to be aware that that's an issue if they do the stool test first.
Okay, so we'll move on to one of our questions from our Q&A box. Are there false positives associated with the FIT testing? Dr. Walker, do you want to field this one?
Yeah, absolutely. So the true goal of the FIT test is to determine if blood is present. We think of it as a colon cancer screening test because often if someone has colon cancer, there might be bleeding from the tumor that causes blood in the stool. But if you have another reason to have blood in the stool, you'll still have a positive FIT test, but you won't have colon cancer. So if someone has inflammatory bowel disease, or if they have something called diverticulosis, where that's bleeding intermittently, even if they have hemorrhoids, anything that causes bleeding will show up as a positive FIT test, and it will take the colonoscopy, the subsequent colonoscopy, to determine, was that positive FIT test because of cancer, or is it a quote unquote false positive because of some other disease process like diverticulosis, inflammatory bowel disease, so on and so forth.
Okay. So it sounds like even though it's a false positive, you still want to go in and get it checked out.
Absolutely, because for one, it could still be colon cancer, and the other part of it is, even if it's not, maybe it's one of these other things that needs to be treated in some way. So, all of those possibilities that I mentioned have their own different forms of treatment that aren't, that don't fall under one umbrella. So it's important to still get the colonoscopy, figure out what caused the positive FIT test, so that you can get the correct treatment.
Perfect. Thank you. And thank you to Heather Dacus, who put in the chat that they're having a national partners are going to be having a discussion about cost sharing guidance for colonoscopies after a positive FIT. So I will make sure that I put that link into the email that everyone will get after this, so that you can find out some more information about some of the questions we had earlier. So another question, I don't have a regular doctor, so how do I get screened if my doctor needs to order one? Any takers? Sparkle, I'm gonna put it on you.
Okay, typically it does need to go, a referral does need to come from your regular doctor. We oftentimes work with individuals in the community to let them know which doctors or primary care physicians are taking on new clients. We partner oftentimes with St. Joe's because our population is specifically people who are uninsured. So we do try and partner with St. Joe's to kind of streamline that process.
And if patients have insurance, but not a doctor, they could still get a colonoscopy just by calling GI or colorectal to get a colonoscopy scheduled if they're of the appropriate age between 45 and 75. But in general, if you have insurance, you should have a primary care doctor to deal with all of your other issues as well. And that person could order the FIT test or order a colonoscopy if needed. But if you can't find a primary care doctor and are otherwise healthy and just need a colonoscopy, you could just call directly for that as well.
So it looks like we actually answered part of this other question. Can a person order the FIT test if they have no insurance? So Sparkle, that would be contact Sparkle and the rest of the Cancer Services Program team. If you don't live in the Finger Lakes, they do have a Cancer Services Program located throughout every county in New York State. So I will be sure to put those links in so that you can find the phone number. You call them and they will be able to find doctors and help set that up so that you can get screened. So we'll go to the other part of that, which is how can a person with insurance order the FIT test if they're not a patient of UR? For example, if they're a patient of Trillium, RGH, or Jordan Health. Q, you want to take that one?
Actually, I think I would still bring that back to Sparkle because I think that that's more appropriate.
So I can't speak for currently, but in the past, when I have partnered with Rochester Regional, they would just have people sign up for their FIT kit and provide their insurance information directly with their colorectal surgery department and the colonoscopy department. For Trillium, I cannot speak to them, but it never hurts to just ask what their policy and procedures are so that you're familiar with that.
All right, I have one more from the registration, and I think Dr. Cannon, this one's probably for you. My cousin had part of his colon removed because of cancer, and now he has a colostomy bag. Is this a usual outcome and is it permanent?
No, that's not a usual outcome at all for a colon cancer resection. I can't speak to that attendees, personal family details because I don't know them, but typical a colon cancer that's diagnosed early can potentially be cured with a removal of that part of the colon with a reconnection of the bowel. So not involving a colostomy or ostomy bag or ileostomy. There are certain cancers, in particular rectal cancers, that are in such locations that if surgical removal is required, that may require a temporary or permanent colostomy. But that's done on a case-by-case basis and is certainly not the norm.
Thank you. I'm glad that question, I did actually have that question myself, whether that kind of is what happens after surgery. So I'm very glad that somebody else asked that. Next question that we have, and I think that this is for all of our medical professionals. Q, if you want to start this one. What is being done to identify folks that are eligible or overdue for these types of screenings?
So for us here, we're doing a lot of community work-based work, getting out into communities, trying to help identify folks, trying to get them to understand when screening that 45 is actually the new starting point, unless, like Dr. Walker had mentioned before, if you have some predisposed factors, then you might need to be done sooner. So we ourselves here at URMC are getting out into the community. We're working with our GI and colorectal team, working with our barbershops and beauty shops, educating them to educate our high-risk populations. We've done work where we've gone to the mall. We've done work with our police task force where we've done organizations through the TIPS program. So we are doing a lot of work to try to educate our community and trying to pass that work forward so the community continues to educate the community itself. And then as well as our providers and our primary health care professionals to make sure that they are also guiding that new guidance at 45 and realizing that the screening is for earlier than what it was previously.
Dr. Walker or Dr. Marino, do you want to kind of mention now your barbers initiative that's being done as part of the community outreach?
Yeah, sure. So we have a coalition, like Q mentioned. It's called Barbered, Beautied, Then Screened. And we educate the barbers and stylists to educate their clients and help them kind of link up with us to get screenings when needed. And that's really focused more on the Black community and inner city population, because unfortunately there are big disparities in terms of the rate of screening for that population. So we're really trying to bridge the gaps and get rid of those disparities through that program. And so we're meeting with the barbers and stylists quarterly and educating them and really forming good relationships going forward. I also just want to say that, this is why it's so important to have a primary care doctor for everyone, because that person really is the quarterback of your care. And so, a GI doctor I don't see everybody. I don't know who needs colonoscopies, but that's what the primary care doctor's job is, to kind of see you, quarterback your care, and make sure you're getting all the health maintenance stuff you need. And, they have certain procedures and quality metrics in place where they need to kind of make sure that all of their patients are being screened appropriately.
I would like to share that the Cancer Services Program, we provide community education. We do partner with Dr. Marino and Nurse Practitioner White as far as their initiatives are concerned, but we do partner directly with people in the community. Our most recent partnership was with the Central Library not too long ago. Like, we will partner with any entity that's willing to let us provide education on the new screening guidelines.
Wonderful, thank you. Dr. Walker, I think I don't know if you'll have the answer to this question, but do you know the video that you shared? Is it available in Spanish?
I don't know, but I'm happy to look into it.
The fit kit that CSP sends out, the video is available in English and Spanish.
So Sparkle, can you share that link maybe with us, and we'll make sure that we send it out. Perfect. Thank you. Nice tag team, guys. Okay, let's see. If I'm screened through the cancer, I think that's a cancer services program, do I have to go to a specific doctor or can I choose?
No, we actually, even though we're under the U of R umbrella, we are funded through New York State, which allows us the opportunity to work with multiple providers. We work with Rochester Regional, we work with Elizabeth Wendy, we work with a variety of providers. We have over 200 credentialed sites.
Wonderful. Thank you very much. Okay, so the next one is more for treatment. So Q and Dr. Cannon, I'll hand this over to you guys. What is the regular treatment plan for colorectal cancer?
That's really an individualized answer, but I will give you very, very broad strokes. So if you are found to have a small early colon cancer that has not spread anywhere, that is most often treated with surgery right away, and that may or may not be all you need. If you are found to have a small to medium-sized colon cancer that is treated with surgery right away and is found to have cancer that has crept to the lymph nodes, that will also require chemotherapy for 3 to 6 months. If you are found to have a colon cancer and during that workup, it looks as though it has already spread to the liver or the lungs or elsewhere in the body, then that is treated first with chemotherapy and occasionally can be treated with surgery for patients who do well on the chemo. For rectal cancer, it's even more complex, and the treatment almost always includes 3 things, which is chemotherapy, radiation, and surgery, but not always in the same order.
And then to add with that, once you're in the hospital, if you do surgery, you are met with an interdisciplinary team, meaning that you have a team of nurses, APPs and colorectal surgery, our residents, our doctors, our social work, our physical therapy. If you end up with an ostomy, then you also have a wound specialist, and we do a lot of education. We guide you through everything in the hospital, make sure that you feel very supported during your recovery, as well as connecting you with resources in the community outpatient, so that when you get home that you still feel supported as well.
That was a complicated question, and you've wielded it very well. I have kind of a follow-up, I guess, to this one. So usually when you're seeing information or presentations on this, it's always colorectal lumped together. Is there a difference between colon cancer and rectal cancer in terms of like how often people get it? Are there certain populations that are more likely to get one as opposed to the other? Does that information exist out there somewhere?
So there are 2 different cancers insofar as the colon and rectum are 2 different organs that are connected together. And the reason they're treated differently has more to do with the fact that the rectum has a lot of different organs that are very close to it in a tight space down in the pelvis. And so that has what has really driven the way that it is treated versus colon cancer, not so much that they are 2 completely different beasts. There are some subtle differences in some of the things that you suggested that are difficult to pull, like, real peaks of significance from, but yeah, there are slight variations in the incidence of colon and rectal cancer in different populations, yes.
We talked earlier with Dr. Marino and I about our Barberton and Beauty program that we have, and especially working with the Black community, especially since they have one of the highest rates. So when you talk about rates, they have a 20% increased rate incidence of developing and also a 40% increase in mortality. So we really try to make sure that we are doing a lot of education with this particular group to try to decrease those disparities and working on how and why it's so important for screening, what we can do to do modifiable risk factors like diet, exercise, things like that, just because they have an increased risk. And we know that colorectal cancer screening saves lives. So we really want to make sure that we educate one of the highest groups that's having an increased incidence.
One other question. What happens if you don't know your family history? So when do you determine then when you get screened? And is there something else that you should do to help figure that out?
That's a great question. If you're able to find it out in any way, that would be helpful. I mean, obviously there are many situations in which you can't, but we're not really, if someone doesn't know their family history, then we screen on average risk. But I think that would be even more reason to be very aware of any symptoms you might develop and not to ignore anything, so that you get seen and evaluated soon if there's anything off. But in general, if there's no family history known, we do average risk screening.
Okay, and then I have, oh, I'm sorry, go ahead.
I'm sorry to interrupt you, Christina. On that note, Danielle just reminded me of something. So, even before, if you're having trouble getting access to FIT, or you happen to not have a primary provider or insurance, some things that you can do every day to keep yourself safe are to look at your poop, get used to what your poop look like. People's poop, changes day by day. It's not always the same. Look at it. Never ignore blood in your poop. Never ignore blood in your stool. Most often it turns out to be nothing, but it isn't something that you should be mentioning to no one and letting it go on. So those are a couple of things that you can do to keep yourself safe from the start.
Very good point.
And that actually kind of leads into the question. I know that we've been talking so much about prevention and different things that you can do to help reduce your risk, and then also ways to be screened so that if it is caught, it's hopefully caught early. But what are some of the symptoms or signs that you might have an issue if you haven't been screened? And this might be something that can prompt someone to get screened if they're having these symptoms.
Sorry. Go ahead, Chris.
Sorry. I was just going to say, one of the big symptoms to look out for is blood in the poop, blood in the stool. That like Dr. Cannon said, should never be anything that is ignored. Other symptoms like abdominal pain or changes in stool calibers or shape are other things to pay attention to. It's worth noting that early cancer or even precancerous lesions often don't have any symptoms. And if someone is developing symptoms, these are concerning for either a lesion that's advanced or a cancer that's been there. So you definitely want to be aware of any new pain, new blood, new changes in stool. These would be concerning. And just to add to the family history discussion that we were having, some people don't know their family history because it's impossible to know their family history, whether that be because of they're not linked with certain members of their family, or they are linked, but their family that the actual family member doesn't know their medical history, so on and so forth. And then other people, it's just a matter of just having that conversation with the family member. So I like to encourage people to try to be engaged with their family members, and certainly as it relates to their medical health. There are things that can come up that we realize might apply to you and not just only your mom or your dad, so on and so forth. There are things that end up being extended to the whole family. And the other part of that is oftentimes, depending on how how someone's health is, they may need support at some point. And it's important to be involved in your family's health so that you can be part of their health, their support network early, rather than when they start deciding to share that things have become advanced. If it's at all possible to learn more about your family's health, I definitely encourage it. Whether or not it's awkward, try to break that and learn more about your family's health.
I would add also to a couple more symptoms that might happen that you might see, especially with family members. It's just like weight loss for no reason. Not that they just started to lose weight, but all of a sudden they're starting to lose weight and there isn't a reason for them to be losing weight. Like Chris said, if Dr. Walker said, if there's blood in your stool, abdominal cramping, inability to tolerate a diet like nausea, vomiting, things like that, things that are just off, like start listening to your body, start looking at what's coming out of your body. And if something's changing, you should probably get it looked at. Because again, we want to make sure that we're diagnosing these at the earliest stages. And like Dr. Walker said, a lot of the times colon cancer actually doesn't have any symptoms. So by the time you actually have symptoms progressing, it probably likely is that the cancer has as well. So we want to make sure that we are treating you as early as possible.
So the biggest takeaway from this whole entire thing is the best test is the one that you take. So please make sure that you talk to your primary care provider or call up Sparkle and her team, and they will connect you with someone to talk to go in and get screened. So as Dr. Walker said, 45 for average risk. If you think you're at higher risk or you have a family history, talk to your doctor to see when you should start getting screened. So thank you so much to our presenter, our panelists, and to all of you for joining us today. I'd also like to thank our interpreters who did a wonderful job to help make this accessible to our deaf community. When this is over, you'll be given a link to a survey. Please go in and fill it out just to make sure that we're providing content that you actually want to hear about. The webinar has been recorded and an email with a link to the video will be sent to all registrants next week. I will also include the other links that we've received, also the links to the cancer services programs throughout the region. And make sure that you join us for our next community conversation on March 16th at noon, where we'll hear about hereditary cancer screening, know your risks. So it actually dovetails perfectly from this one. So I hope to see you all then. Thank you for sharing your Friday afternoon with us.